Welcome back to Health Law Pulse. I'm your host, John Rhodes, healthcare attorney and founder of Health Law Counsel, LLC. Behavioral healthcare is one of the most discussed challenges in healthcare today. We hear a lot about expanding access, improving outcomes, and addressing the mental health crisis. But the reality of delivering behavioral healthcare, particularly for underserved populations, is often far more complicated than the policy discussions suggest. What does access to care actually look like in practice? Where do patients fall through the cracks? And how do providers balance regulatory requirements, operational realities, and patient needs in some of healthcare's most complex environments? My guest today is Corey Shumate, a psychiatric mental health nurse practitioner and doctor of nursing with extensive experience caring for patients with depression, anxiety, ADHD, mood disorders, substance abuse disorders, and sleep disorders. His career has taken him from psychiatric nurse and nursing supervisor to advanced practice provider, giving him a unique perspective on both the clinical and operational challenges facing behavioral health care today. In this episode, we discuss expanding access to care beyond policy discussions, the realities of telepsychiatry, opioid treatment in the real world, and why conditions like ADHD and anxiety are often overlooked or undertreated in underserved populations. This is Health Law Pulse. Corey, welcome. Thank you for your valuable time joining us on this episode of Health Law Pulse, which will actually be the last of our first season. So very excited to have this conversation. Appreciate your insight and expertise.
Thanks for having me.
Yeah, absolutely. So, Corey, I like to start every episode. If you could I think it gives great context for the discussion that we're going to have. Give us a little bit about your background, what you've done in your career, what you're doing now, and we'll go from there.
Yes, I'm a psychiatric nurse practitioner. I have the terminal degree in nursing, which is the doctorate. So I'm a doctor of nursing, not an MD. Let's make that clear. I am a doctor of nursing, though. I started my career off as a registered nurse. I've only worked in psychiatry. I've never worked outside of psychiatry. I was a registered nurse for probably about 10 years. And then I've been a psychiatric nurse practitioner for about 8. And I've had my doctorate for about 2 years now. I own an outpatient practice. It's called Ear-to-Ear Behavioral Health in the Chicagoland area. And I also work inpatient, which is more acute, at a hospital in the inner city of Chicago.
Excellent. Thank you. I love it. My wife's an RN, and I have the utmost respect for the nursing practice. I think it's got to be one of the hardest jobs in the world. And so certainly appreciate your work there. So, Corey, I think your work in the behavioral health space, particularly with respect to the Medicaid population. I want to talk a little about access to care, which I know you are very passionate about. It's a topic that I think is addressed. I work with a lot of behavioral health providers, but access to care is something that I think we need to talk more about. We just got done, I think May was Mental Health Awareness Month. I think June, correct me if I'm wrong, I think June is, we're recording this in June, is Men's Mental Health Awareness Month. And so I think it's an appropriate topic, certainly now, anytime, but certainly now. We hear a lot about expanding access to behavioral health care.
Mm-hmm.
I don't think you'll find a person that says we have enough access. Access is good. We're good. But from your perspective, what does that actually look like in practice? It's beyond the just talking about, access to care is important. What does that look like to you in practice?
Yeah, access to care. That's a good topic, actually. I would say coverage is not the same as access. So access is when a patient can actually get evaluated, actually be treated, followed and respected. I think on paper, when people mention access, Medicaid covers, Medicaid particularly, and I'm talking about Medicaid because my outpatient practice is 95% Medicaid. And then the inpatient setting that I work is strongly Medicaid focused as well. I would say Medicaid covers psychiatric services, therapy, telehealth, medication management. And in practice, access means the patient can actually get an appointment, connect to the visit, receive a culturally respectful evaluation to get medications filled before they deteriorate. But in the Chicagoland area, the Medicaid patients face long wait times. So they have insurance coverage, but the typical wait, I was looking at a study not too long ago, I think it was a JAMA study, or it might be called YAMA. And they said that in Chicagoland area, the typical wait time to see a provider is 23 days. And other cities, it may be even longer. And in 23 days, I think it's short-sighted. I know personally, patients that I see outpatients say, hey, I may have not seen a provider for 3 months, or I've been on a wait list for 3 months. So although they have coverage, although they have insurance, they still don't have the access because they wait in these long wait times. So the matter is because 3 weeks could be the difference between outpatient stabilization or ER visit or hospitalization or relapse or homelessness or incarceration for this particular population.
Yeah, Corey, that's really interesting because I do think that generally speaking, we think, I mean, from certainly from a policy perspective, it's hey, if it's covered, there's access, right? And so there's a big push to make sure that behavioral health services are covered within particular public programs. But what I hear you saying is that that's just not enough. I mean, it's one thing to reimbursement that doesn't necessarily equate to care. You mentioned the 23-day to 3 month wait time. What do you think? I mean, from what you're seeing, what is attributed to that? Why the long wait times despite the fact that it's covered service under these programs? What's the breakdown for most of these Medicaid patients?
Yeah, a large contributor is even in the private practice sector. Matter of fact, especially in the private practice sector, a lot of clinicians do not accept Medicaid.
Mm.
So that contributes to the access problem because the people that need the services the most, they can't get the care because many clinicians do not accept Medicaid for a multitude of reasons, including reimbursement. The reimbursement is lower. I would say the administrative burden is higher. No shows are common in this population due to social instability. All of those things contribute to the access problem that we currently are facing.
And these wait times are, and this is just to get an initial evaluation done, right? So, in your perspective, you mentioned that you're right. I mean, three weeks to 3 months that can mean the difference between a lot of things, between getting the care they need and in some pretty dire situations. Are you finding that those that finally get in to see a provider, they have real acute needs that, I mean, that could have been prevented is not the right way to phrase it, but I mean, certainly would have benefited with being treated earlier.
Oh, absolutely.
Yeah.
I think another thing that small practices like I have and a lot of other clinicians have is visibility. So we're competing against the larger organizations. So although we have open availability maybe that week, no one knows who we are. You
Mhm.
understand what I'm saying? So the marketing engine is extreme. And again, these people that require these appointments or looking for these appointments are definitely in acute stress and they can't get in. And like you said, if they can't get in, it's going to affect us as a population, taxpayers, because they're going to go to the ER. And going to the ER is too expensive just
Yeah.
to be treated for something simple as anxiety or a panic attack. You go into the ER for emergency medication that you could have got from your provider outpatient, but you can't get a provider because none are available that you know of.
Yeah, that's a really great point. And the cost, the cost increases exponentially, right? If someone isn't getting the care they need, and it turns into an acute situation, they do it up at the ER. And we're just talking about the population of people who are trying to get into see a provider, right? That doesn't even account for the people who may just seem frustrated by the process, just don't know about the resources that are out there in terms of getting them the care, and maybe it seems overwhelming. I could totally see that
Hmm.
seems overwhelmed by the whole process, and so doesn't even try. There's a whole population we're not even talking about here. We're just talking
Right.
about trying to get in to see a provider.
Exactly.
Yeah. Well, one solution, I work with a number of telehealth, behavioral health providers. That is a solution that's emerged rapidly over the several years. Obviously, that comes with its own challenges. Telehealth has transformed, I think, behavioral health care. What benefits have you seen firsthand from being able to provide virtual care as a means of increased access?
Oh man, I think if anything good came out of the COVID-19 is telehealth
Yeah.
because telehealth has expanded the access to caring for people. Like I could see a patient here from Chicago. I live in Chicago, in the Chicagoland area, but a lot of my patients are downstate, 4 hours away, still in Illinois, where providers are not in abundance down there, but now they can still get the care that they need and deserve from a distance. So telehealth removes transportation barriers, but it creates new barriers such as unreliable telephones, limited data, lack of privacy, low digital literacy, I would say, unstable housing, and missing portal messages. But it absolutely has transformed care because you don't have to be within a certain city or a certain location or certain miles to get the care that you deserve anymore.
Yeah. So it's sort of broken down those geographic barriers. But to your point, there are a lot of operational challenges still with delivering
Hmm.
psychiatric care virtually. Are those the main challenges? It's just access to the tools needed to access that care?
Yeah, I would say those are the main challenges for the patient. For providers, I would say like licensing and location, because providers must be licensed where the patient is located at the time of service. And telehealth, you need to confirm the patient's location every visit, especially if they're near, like I just mentioned, like state borders, like say at Belleville, which is close to St. Louis, or suburbs like close to Indiana. That patient still has to be in Illinois. And
Right.
then another challenge that providers may run into is the controlled substances. A lot of the pharmacies don't want to dispense when the provider is in Chicago and the patient is 50 miles somewhere else. Some of the pharmacists want the patient to be seen in person one time, or you know what I'm saying. So federal telehealth rules allow us to prescribe stimulants and controlled substances, but we still face those barriers of whether the pharmacist is going to dispense it or not. And then you may run into things like drug testing and things of that nature.
Yeah, you bring up a great point, and that is an issue I've dealt with a number of clients. It's the federal telehealth flexibilities have been extended 4 times. Now there's legislation that at least extend most of these flexibilities to the end of 2027. That said, you're dealing with a whole different, one of those flexibilities was from the DA side was you didn't have to have a DA registration in every state where you provided services. But notwithstanding, there are certain state requirements or there are certain pharmacy requirements that say, hey,
Right.
we're not even going to fulfill these prescriptions unless you have a DEA registration in this state. So it does still provide some barriers. I work with some 50 state telehealth companies and the kind of dealing with the varied state laws with respect to licensure. Certainly, I think it's pretty common that you have to be licensed in the state where the patient resides.
Hmm.
But then there are so many other rules and regulations with respect to supervision, with respect to, privacy requirements, things like that it's tough when you start talking about multi-state telehealth platforms. We're talking about some of the operational challenges. That's certainly one of them.
Yeah, yeah. And then here in Illinois, it's funny because I'm full practice. Illinois is a full practice state, so I don't need supervision.
Mhm.
After a certain number, practitioners don't require supervision after a certain number of hours. You can prescribe freely without oversight. But again, some pharmacists still, hey, who's your consulting or you're collaborating your doctor? I'm not going to fill this medication
Yep.
because of that.
Yep. Yep. Yeah. Those rules just vary from state to state. Hey, Corey, I'm going to switch gears a little bit and talk a little bit about the consequences of some of the access issues we're talking about. You have mentioned before that ADHD and anxiety, they are tend to be missed or not
Yeah.
diagnosed in underserved populations. Why is that? Why are these ADHD and anxiety, maybe some other diagnoses that are missed in lower income communities?
Oh gosh, that's a good question. So yeah, when ADHD and anxiety are missed, the system often punishes the symptoms
Hmm.
instead of treating the condition. So what I mean when I say that ADHD and anxiety are often missed in the lower income communities because symptoms are interpreted through a behavioral or moral lens instead of a clinical one. Let me give you an example. So you would say something like a child with ADHD in these communities, lower socioeconomic communities, a child with ADHD may be labeled as bad or defiant or lazy. Or an adult with ADHD may be labeled as irresponsible or drug seeking or non-compliant with medication. A patient with anxiety may be told that they are dramatic or manipulative or they may be stressed. When we know that ADHD is neurodevelopmental and it involves inattention, impulsivity, hyperactivity, it can affect school, work, relationships, and daily functioning. And now adults, we know that up until now, mental health, it was a stigma. So our parents just told us that we were hyperactive and we couldn't sit down.
Right.
So they were never taken to a psychiatrist or a nurse practitioner back in the day to just say, hey, put up your bootstraps, sit down and get through it. So ADHD went undiagnosed in our adult populations, but then they become adults without their parents' oversight now. And they say, hey, I still have these symptoms that I had as a kid, and I can't manage work, and I can't manage my day-to-day functioning. I need to be evaluated." And a clinician would say, "Hey, were you evaluated when you were 12 years old? Because ADHD started as a kid."
Yeah.
Like, no, my parents wouldn't take me. You
Yeah.
understand what I'm saying? So it's a combination of those. So
Yeah, there's been a there's certainly been a shift, over the past generation or two in terms of that stigma. And so is that what underdiagnosis looks like in your practice? So you see these adults that probably exhibited these symptoms as a kid. It was just never treated for one reason or another, and then it manifests in something more acute. Is that essentially how it goes?
yeah, that's just how it goes because they've never been treated. And then, John, we know that stimulants are the number one treatment for ADHD. We just talk about ADHD now. But in the Medicaid population, they still want us to start with a non-stimulant. So a lot of the patient stigmas and the reason that they didn't want to come to us in the first place
Mm,
are thrown at the forefront of the game because they think they're guinea pigs again. Like, hey, give me what works. Don't try me on a medication that's 50% of the chances it's not going to work. Like a bupropion or atomoxetine, a non-stimulant. When the literature says, hey, stimulants are the number one choice for ADHD, but Medicaid says, hey, you have to try the non-stimulant first.
mm.
You understand what I'm saying? Or we're not going to approve this stimulant until you try the non-stimulant. And now the patient think they're guinea pigs. So we run into that as well.
Yeah. And what are the downstream consequences when treatment is delayed for years? What have you seen in your actual practice when this comes up?
Oh, well, in school with the adolescents and pediatric, a lot of them are displaced to different schools because teachers can't handle them. They're disruptive. They don't sit still, and too many calls to the principal, so they may get displaced to an alternative school. With our adults, they just can't get anything done,
Yeah.
which cause relationships problem. They start cleaning the kitchen, and then they start taking out the garbage. You start taking out the garbage, and then they start folding clothes. So you have relationship problems as well as work related problems where they can't or they believe they're not performing to their job standards, and it may cause problems at the work.
Yeah. I mean, for risk of stating the obvious, the earlier the better in terms of getting the care that someone needs to try to avoid all those acute situations and some of the downstream consequences. Corey, I want to talk a little bit about the intersection between mental health and social determinants of health. And social determinants of health is something that I'm pretty passionate about, and I work with a number of folks that are in this space. And really, because I love the idea about treating the whole health of a person. I think there's more than just symptoms that are related to someone's healthcare. And how much of what you treat is truly, do you think? There's a balance. I'm sure that it's both, truly psychiatric versus driven by maybe social economic stressors. That you see both quite commonly. Is there one that's more predominant than the other?
That's a good question. I would say on the inpatient setting, access for, which is psychosocial, is more predominant. It's probably more predominant. If it's not more predominant, it's 50-50 with the access one, which is more diagnostic. In the Chicagoland area, surviving is very, very important to a lot of people. And the psychosocial determinants can intersect with the clinical, but just surviving. Where am I getting my meal? That, where am I going to live? In an inpatient setting, we see rapid readmissions all the time. And it's not, I mean, they come in, and I'm not going to say that what caused them to be admitted. I'm not going to say it's not what they say to
Right.
get admitted,
Right.
but we know as providers that it's a housing issue.
Yeah.
And a lot of our hospitals are used as shelters now and used as a stable place to get 3 meals a day and see people that they recognize. A lot of people don't have family, or a lot of people have poor social supports. So the hospital has become a shelter. It became a place of familiarity, and it became a place just to survive and eat. So I would say the access for is very, very important, if not more important than the access one, for sure.
Yeah. So it sounds like a pretty critical role in these types of things play in behavioral health outcomes like housing stability, transportation, food insecurity, employment. I mean, what role do they play in actual outcomes related to behavioral health?
Yeah, and then with outcome, I'm glad you mentioned outcomes. I think one of our biggest problems is even when we stabilize a patient, we discharge them back into those same environments.
Hmm.
So they discharge back into the same environment that they created, the trauma that created, that may have contributed to clinical presentations. So until we figure out, hey, what can we do after stabilization to actually continue the treatment? You know, there is a discharge plan, right? It's a discharge. We're going to discharge you here. We're going to discharge you there. But the follow up sucks.
Right.
Just for lack of a better word, like a better term. HIPAA is good, but HIPAA is bad.
Hmm.
Because HIPAA, you can't get any information on these people. You can literally discharge the person to another place, and then you may need a signed authorization to release information when you know that you just discharged this patient. So the continuity of care is lacking in our field, and that's something that we need to target.
What I totally agree with that. And so the golden question then is, what can healthcare organizations do to better address these issues? Like, how do we improve continuity care? How do we, when we discharge someone from an acute inpatient psychiatric episode, and we know that some contributors to that are some of these social determinants of health, these, housing instability, things like that. How do organizations better address this?
Yeah, I think the major issue, John, is business versus business. But without controlled substances, right?
Hmm.
We could go onto the monitoring system, like it's called an Illinois PMP here in Illinois, to see where you were last prescribed your Adderall. You picked it up on this day from this provider. I think if we had a system like that they go across all hospitals and all facilities, then the continuity of care be better. But it just haven't been one invented for whatever reason. You know
Right.
what I'm saying?
Yeah, yeah, there are organizations out there that address food insecurity, that address it's just, to me, it's just a matter of let's get. And I know that every health system has their own health equity people, and they're trying to help increase coordinated care. It's just tough. It's tough to scale that without.
Right.
So I think regionally maybe it's being handled, but I mean, to the best, I think a single organization can handle it. But in terms of scaling that and getting real meaningful folks and just try to help people who are falling through the cracks, I think is just tough. What do you think? We kind of talked about this at the beginning. What's the biggest misconception that policymakers have about access to behavioral health care? Is it just the reimbursement stuff? Like if it's covered, it's covered, or what do you think is missing there from the policymaker perspective?
Yeah, I think I'm not big on policy either.
Yeah.
But, I think policymakers believe that because patients have insurance, that they automatically have access. And
Hmm.
access and insurance are totally different. Like you said, I think it just need to be more visibility of the smaller people because the smaller people have the smaller businesses. The smaller businesses, they have availability. It's just
Right.
no one knows who they are. So the policymakers throw a lot of money, I believe, into these larger organizations, the larger hospitals, right? But the larger hospitals have the wait list. So a lot of the smaller private practices who may have availability don't have that same marketing engine behind them. And I think the policymakers probably, at least the local policymakers, at least should probably look more into these smaller practices and promote them because they believe that it's access, but it's really not.
Yeah, I'm on board with that 100%. So like a grassroots more lift in terms of marketing the actual resources, finding a way to get the information out there, providing incentives for these smaller practices to help treat these patients and to increase
Yes.
access. All excellent points. I want to be a little bit future looking, Corey. So what gives you optimism about the future of behavioral health?
Oh man, you know what? I would say these last 3 to 5 years,
Hmm.
the stigma of behavioral health has declined. I would say that. A lot of people are seeking out therapists for their mental health issues. And I believe society as a whole has actually accepted that mental health is actually a chronic condition for a lot of people. And because of those things, and because it's more marketed as something that's good, therapy. Hey, your mental health needs to be better. Put your mask on first before you can help somebody else. that gives me optimism that the mental health is going in the right direction. And you remember, like I said, when you and I were kids, it was no, I'm not going to see. They call him a shrink at the time. I'm not going to see the shrink. You're not going. You okay? Everything that's going around you, but now it's not like that.
Right.
Now it's, hey, how can I help you? Hey, are you doing okay? Do you need to go talk to somebody? And it's accepted as norm now. So that gives me optimism for the future for sure.
Yeah, awesome. It does feel like it's heading in the right direction. And more people to talk about it, I think that stigma. So I think that's really important. Well, look, Corey, this has been, I love this topic. I love this discussion. I appreciate your expertise and insight. I want to wrap up with as we do with every episode, of the lightning round. And as everyone knows, the lightning round is sponsored by Western Associates. They specialize in high quality branded merchandise, things people actually keep and don't throw away. If you're thinking about upgrading your organization's brand, I highly encourage you to contact Western Associates at westernassociates.com. Connect with my good friend Mike Eldridge at MELDRIDGE at westernassociates.com. We'll also drop a link in the episode description as well for your corporate branded high quality products. Corey, it's just three quick lightning round questions, and then we'll wrap up. What is the most important quality in a behavioral health provider?
Compassion, and care for sure. You say three.
Yeah,
Compassion.
just one. That's good. That's all important. I'm sure there are a lot. One healthcare policy you would change tomorrow?
Policy. Again, I'm not big on policy, but I think we talked about having a DEA license. I think you should have a DEA license in every state that you work, but I don't think you should have to have an office. A lot of times you have to have that office or live in that state as well. And I think I would change that requirement if I can.
Yeah, and for context, yeah, so right. So some of these states require you to have a physical location, even if you're
Okay.
providing telehealth services.
Yes.
Seems counterintuitive, but yeah, I'm with you there. And Corey, just to end off, like again, this is something that is very personal to me. One piece of advice for someone struggling to seek help.
Oh, I would say don't be afraid. Don't worry about the stigma and be open and be vulnerable if you can.
Yeah, it's a great message. I don't speak about this very often. I went through a period about 10 years that was pretty dark for me. And finally, and I think during that 10 years, it was we talked about the kind of the Gen X stigma of, we don't need to go see someone. They like, what is that going to do? It's just, I'll just sort of push it down or keep moving forward. And my personal experience is that absolutely does not work, and it gets worse and worse and worse. And finally, I went to go see someone, and I was seeing someone for over a year, and I mean, it changed my life. So I share that encouragement, the piece of advice that you just provided to someone who's struggling to seek help. Do not delay. More people need to talk about this. There needs to be change from a societal standpoint, from a policy standpoint, from an access to care. I think we just need to do better. We just need to be better. And if we're personally struggling with something, we need to go find someone to help us.
Yeah, and I leave with this that mental health care, it isn't just about prescribing medications. It's about creating conditions where recovery is actually possible.
Mhm.
When a patient has stable housing that we talked about, consistent access to treatment that we talked about, and basic safety, psychiatric medications work better, therapy work better, and hospitalization and ER rates drop dramatically.
Yeah, absolutely. Corey, all excellent points, great insight. I sincerely appreciate your valuable time sharing with us, sharing your expertise and insights. And thank you so much for joining Health Law Pulse.
All right. Thank you, Mr. Rose. I appreciate you.
Thank you. Take care.
Wow, this has been a really important conversation, both personally and professionally for me. A few takeaways stood out to me in this conversation with Corey. First, expanding access to behavioral health care is about much more than increasing availability. It requires addressing the operational, financial, and social barriers that prevent patients from receiving care in the first place. Second, many of the greatest challenges in behavioral health care aren't clinical, they're systemic. Whether it's access to specialists, continuity of care, reimbursement challenges, or social determinants of health, the system itself often creates obstacles for both patients and providers. And third, behavioral health care deserves the same level of urgency, investment, and innovation that we bring to other areas of medicine. There's just no doubt about that. The downstream impact of untreated mental health conditions affect patients, families, schools, workplaces, and entire communities. I want to thank Corey for sharing his experience and perspective on these issues and for the work he is doing to care for some of the patients who need it the most. At the end of the day, improving behavioral health care isn't simply about expanding services, it's about building systems that make care accessible, sustainable, and effective for the people who rely on it. This episode marks the last one for the first season of Health Law Pulse. We're taking a break this summer, but we'll be back for season 2 in September. I want to thank all of you for listening and engaging in some really important topics within healthcare. I'm truly grateful and blessed to be involved in this space, and for all those who agree to be season 1 guests. I really appreciate your time. Have an incredible summer, and we'll be back this fall. This is Health Law Pulse.